ساعتها مش ناسي.
انا مش هدفع بيه. طيب كملت
كل
كام؟
عام
70
وحضرتك
سنة؟
Introduce tonight one of the most important international webinar tonight. We have three guest speakers tonight, and the chair of this session are Prof. Assam Manna and Dr. Adil Ibrahim. All of yours, Prof. Assam. Thank you very much.
Thank you so much. Good evening, everybody. Assalamu alaikum wa rahmatullahi wa barakatuh. بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. I think, but I'm sure that all the attendees and the panelists, they agree with me that science everywhere, and you can get science from books, from any materials, but experience is not everywhere. Experience is very seldom and very rare and very crucial. And one of the target of our mega online course is to get experience and to bring experience for everybody all over the world. And it proves this webinar. It is one of the best webinars in the field of anesthesia, intensive care, and pain management. And now we are followed by everybody all over the world, from the Far East, from Middle East, from Latin America, from Europe, from USA. And today we have very distinguished and eminent speakers. And as usual, and Professor Samir Al-Ansari is a star and the icon of our mega online course. He will introduce his series about the nutrition in the intensive care. And the second speaker will be Dr. Hazim Yassin from Saudi Arabia. And the last speaker will be Professor Barbara Rogers from Ohio, USA. And this proves what just I said, that we are bringing all the experience, most of the experience. Now we have experience from the Egypt, from Saudi Arabia, and from America. And we provide all of this experience and science to the attendees on a golden plate. I appreciate the presence of our distinguished speakers, and we will speak today, as we said, about intensive care and anesthesia. And it is a great honor for me. He will share with me in introducing the speakers, Professor Adel Ibrahim. Let us start with our eminent and distinguished speaker, Professor Samir Al-Ansari, with his series about the nutrition in the ICU. So please, Professor Samir Ansari, go ahead, and the floor is yours, sir.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Assam, for this nice introduction and nice words. Good evening, my dear colleagues. Good evening, our attendees. Today, we are going to, in continuation for our series of nutritional support in the ICU. We will continue today with and start with TPN calculations. I try to get the, sorry, 1 minute.
نعم. Yeah, slide share. Is a screen share here in the middle? You kindly press the screen share screen. Bro, yeah, good man, thank you. Thank you, bro.
واضحة كده؟
Yes, sir. Yes, sir.
كبير, huh?
Yes, sir.
Sorry for these interruptions. Today we are going to continue my series of nutrition support. I will speak today about total parenteral nutrition, and I will concentrate today on the formula calculation, how to calculate the formula for nutritional support or for TPN. As we know, at start, you have to evaluate your patient. You have to assess your patient. As we said before, you have to know the lab results first, how much he will need from carbohydrates, how much he will need from proteins, from lipids. Suppose the patient suffering from high triglycerides, you have to go down with lipid support. You have to assess your patient. After that, you will decide if you will start with total parenteral nutrition support or with partial nutritional support. As you know, most of you know, there are two types of parenteral nutrition. Peripheral nutritional support through peripheral vein, if the central vein is difficult for you, and the total parenteral nutrition support. In peripheral support, we give some enteral nutrition and just supplementation with additional parenteral nutrition through peripheral vein. But we have to decrease the osmolarity of the infusion calories. We have less 100, 900. If the osmolarity is high, you can't infuse through a peripheral vein. And so the peripheral parenteral nutrition is a temporary support or a temporary bridge till you achieve a full enteral nutritional support. Routes of administrations, and so if we speak about peripheral parenteral nutrition, It is a short-term use only, not for a long time, just a temporary support, as I said, and the osmolarity is low. Dilute solutions, low osmolarity. Formula osmolarity is less than 900 or 600. Fluid restriction is not necessary because in peripheral nutrition support, you have to give a large volume of solutions to decrease the osmolarity of the nutritional formula. For TPN, we, of course, select a central axis. Central axis may be through the subclavian vein, internal jugular vein, or femoral vein, or through peripheral central cannulations or PICC line, or through the cubital veins. Total parenteral nutrition must be individualized for the patient. There are standard concentrations of protein, carbohydrate, and fats available, standard volume. As we have before, the 10% glucose, 50% glucose, 70%, also lipids 20%, 10%, protein, amino acid concentrations 10%, 15%. These are standard concentrations available in most of the hospitals in which there is no lab for nutritional support preparation. Most of the world have a lab, nutritional lab, for preparing the formula or for modulating the formula according to the patient needs. And I think it varies from patient to patient. And so we have to prescribe the ingredients which are suitable for every patient. And of course, it differs from patient to patient. But in the markets, there are solutions ready or formula ready, which contain the 3 macronutrients together, carbohydrates, protein, and fats together in one bag. And the others contains two ingredients, carbohydrates and protein, and the fats could be separated, infused in separate solutions. And so the standard concentration which we used before is limiting the degree of individualization using these standard solutions. And so better to have a nutritional lab in your hospital to formulate according to patient's need how much carbohydrate, how much proteins, how much lipids. However, mixing different formula in calculated amount can be used to develop the feeding solutions for most patients. And as we see here is pictures of 3-in-1 solutions as KBVN, and I think most of the hospitals are using it. It contains protein, carbohydrates, and fat together, and we can mixing the bridge in between that and infusing through a central line. These are examples of already prepared solutions for infusion for TPN. We have to ask ourselves, what is the patient energy? How much calories this patient requires? And I think we discussed this one in the previous lectures. We have 3 methods, as we know. The most accurate one, which depend on indirect calorimetry, which depend on carbon dioxide production, how much, and oxygen consumption, how much, and you can get these 2 items from the ventilator, and so used for patient on ventilator. And this mostly is the most accurate one for calculation the calories which we enumerated last time or last lecture. And the standard one or the routine used one, which is the roughly one or standard one, about 25 to 30, 35 kilocalorie per kg per day for the patient. And we can increase if the patient is passing or staying in a severe catabolic state. After that, you have, after calculating the calorie requirement of your patient, you have to calculate also the fluid needs per day. How much fluid, and there are several methods, as we said. First, 10 kilo, about 100 cc per kg. Second, 10 kilogram, 50 cc per kg. And over that, 20 cc if the patient age less than 50 years. Also, don't forget, in addition to the macronutrient which you add to TPN, which is dextrose, amino acid, and the lipids, the electrolytes, sodium, chloride, magnesium, potassium, phosphate, and calcium. And this is very important, in addition to trace elements. And I think today I will not speak about trace elements. I am going to speak about trace elements in a separate lectures, mostly next week. This is an example of two-in-one solutions. They can use dextrose, macronutrient dextrose, and amino acid here, in addition to other bag containing the lipids. And you have to decide how much vitamins you need, how much minerals you can use, and according to patient situation. How to write TPN? There are several steps, and we must be oriented with that. Identify the energy needs, as I said, calorie, how much calories you need, and then the first step, distribute this energy. Suppose you have 2,000 calories, and you have to distribute to the 3 macronutrients: carbohydrate, protein, lipids, and so on, according to percentage which you select. We mostly use 60 to 65 for carbohydrates, 30% for lipids, and the remaining for proteins. And suppose your patient is in severe catabolic state, you have to add proteins and decrease the other ingredients. And so this is a formulated or modulated formula according to patient needs. After you calculate the energy, and after distributing it, you have to convert the energy to grams. You have to change the energy to grams. And after that, convert the gram to solutions. And so the first step, calculation the calorie. After that, distribute the calorie to the 3 macronutrients you have. And then it changes the calories to grams, and it changes the gram to solutions or volume. 3 steps you can write through it, you can write your formula. Macronutrient distributions, simply we use this formula. Protein 10 to 35%, according to suppose patient with extensive burn, you have to increase your percentage of protein, multiple trauma or extensive trauma, and so on, catabolic state or the early state after trauma, or even in the anabolic state, which is the third state, which I said about it or speak about it in the last lectures. Fat from 20 to 35%, carbohydrate from 45 to 65%. And then add your electrolyte requirement, vitamins, trace element, and the minerals and the medications. And as we know, most of you know, trace element estimation, mostly we use roughly estimations, not depending on the lab estimations. But you can suspect it from certain equations and from certain enzyme estimations and some functional assay. And I will speak about it in detail next week. Energy kilocalorie distributions, how? Suppose this is an example of how to formulate your calories or how to write your formula of TPN. Suppose your patients needing 2,000 calories per day. Substrate distributions, protein I will give 20%, for example, and so I will give him 400 calories. Carbohydrate 50%, I will give 1,000 calories. Fats 30%, I will give him 600 kilocalories. Then I change this calorie requirement into grams. Protein, I will divide 400 kilocalorie protein by 4, will give me 100 grams. Divided by 3.4 will give me 294 grams of carbohydrate or 300 grams of carbohydrate. Every gram of carbohydrate in TPN give me 3.4 calories. Fat I will divide by 10 will give me 60 grams of fats or lipids. And after that, I change this gram to volume, to solutions. Protein, suppose proteins you will need 100 grams, it will be available in 1,000 ml of 10% amino acid. Every 100 ml of amino acid, 10% contain 10 grams, and so the 1,000 contain 100 grams. Carbohydrate also, suppose you have solutions of 50% dextrose. This meaning 1 liter of your 50% containing 500 grams of dextrose, and so you will use 300 grams. Fats, every 1 liter of 20%, of course, will contain 200 grams of fats, and so the 50 grams will be available in 250 ml. This in case of you have a fixed or standard concentrations of TPN solutions in your hospital. But suppose you don't have these solutions, or on the other hand, you have a nutritional lab on your pharmacy, you just write, I need how much calorie from every macronutrient and send it to the lab. Or you can summarize it or change it to percentage. I need how much percentage from lipids, how much I need, for example, 2000 cc of TPN containing 40% protein, containing 50% carbohydrate, and we modulate it according to our patients, and I will give example for this. Calculating the osmolarity of parenteral nutrition solutions to be sure it is not high. And I want to say something. This is not meaning you infuse through a central vein, there is no complications. Thrombotic complications encountered, and we see it even with 5% glucose for long period of time through the peripheral vein. Also, the central vein, subclavian, internal jugular, and you must be oriented all the time and suspect these complications. If you use high percentage of carbohydrates, 70%, 50%, for a long time, suspect you will see some complications as thrombophlebitis in this vein, and we see many patients with thrombotic complications in the subclavian, and the swelling and redness and inflammation in the upper half and obstruction and so on. And so you must be aware of this complication, but you have to calculate the osmolarity of parenteral nutrition before using. And this is a simple equation for calculating the osmolarity. How many grams of dextrose multiply by 5? How many grams of protein multiply by 10 and multiply the lipids by 1.5? 5 for carbohydrate for dextrose, 10 for protein, and 1.5 for lipid. This and the summation of this number give you the osmolarity of your solution. Dextrose 5 and protein 10 and lipids 1.5. This is an example of automix, and there is automix for lab for nutritional lab in the pharmacy inside the hospitals, and prepared from a large volume of concentrated solutions according to order you send or according to the nutritional sheet you send to the pharmacy. Macronutrient concentration percentage, which is grams of solute per 100 ml of fluid. I give you some examples how to calculate. Suppose you have dextrose 70%. This meaning every 1,000, every 100 contain 70 grams every 100 ml, and the 1 liter will contain 700 grams. If you times by 3.4, give you the total calories in the 1 liter of the 70. 10% amino acid solutions contain 10 grams per 100 ml and 100 grams every 1,000. 20% lipids contains 200 grams every 1 liter. Sample for dextrose calculation, 1,000 ml of D50 will contain 500 grams of dextrose, 100 kilocalorie by multiplying 500 grams dextrose by 3.4 kilocalorie per kg. TPN, carbohydrate, every gram give me 3.5 kilocalorie per kg. For lipid calculations, lipids, if 10% solution, every cc will give you 1.1 kilocalorie. In 20% solution, and I think this is the most one used, and we prefer it for containing essential amino acids, every cc containing 2 calories per ml and 20% lipid. Calculation of dextrose amino acid with BG-back lipids. In this method, we use mixtures of carbohydrate and protein, and in addition, another bag containing the lipid emulsions or lipid solutions to be infused. Examples for calculations. I will give example here for calculations of 2N1, 2 macronutrient, carbohydrate and protein in one bag, and the lipid in a separate bag. Suppose my patient need 1,800 calories and protein 88 grams and fluid 2,000 cc. I will subtract first the fat content to be put in a separate bag because I will use two bags. One bag containing carbohydrate and protein, and the other bag, second bag, will contain lipid. And so I calculate the lipid, 1,800 kilocalorie times, I suppose I want to give 30% of calorie as fat. I will get 540 kilocalorie as lipid. We can use it for, we can use 10% solution or 20% solution. If I use 10% solutions, I will divide 540 kilocalorie by 1.1, every cc containing 1.1 kilocalorie. And so will give me 491 cc for 24 hours. The divided it by 24 hours, it will give me 20 cc per hour infusion of 10% lipid. And so I calculate how much calories I need from lipids and separated it from the total solutions, extracted it from the total solutions and put it in a separate bag and infused it over 24 hours or over 12 hours according to time. We prefer always lipids to be infused over long period of time to avoid the rapid increase in triglycerides and lipids and so on in the blood. Mostly we infuse over 12 hours. If you infuse over 12 hours, you will divide by 12 hours. It will give you about 40 cc per hour of 10% lipid. After that, this is the volume of lipid in the second bag. I extract it from the total fluid the patient will receive, 2,000 cc, minus 491 for lipids. The remaining fluid, 1,509, will be in the first bag, which will be distributed to both carbohydrate and protein. Protein calculation, after that, suppose the patients need 88 grams of protein. I will do, according to body weight,
So it seems that something technical issue.
Any problem, Professor?
He should join very quickly now. Sorry for that. He's back.
Yes.
He's back.
you hear me, Dr. Saad?
Yes, sir. Just you
what's-
kindly share your screen again, please.
Hmm?
You share your screen again, please. Yes, that's perfect. Thank you.
I stopped here or interrupted here?
Yes, before just the protein calculation.
Protein calculations, okay, sorry. Protein calculation, suppose I selected 88 gram protein for these patients. I divide by the total volume for the first bag, which 1,509, and multiply by 100. I will get the percentage of protein or amino acid solution. After that, I calculate how much calorie from protein I give. I give 88 gram protein times 4 calorie for every gram. I will get 352 kilocalories. And so I have to extract from the total calories which the patient need 1,800 minus 540 for lipids and 352 for protein. The remaining will be 908 kilocalories, these for carbohydrates. And so, as we see, we change we calculate the calories first for fats and extract it from the total calories and then distribute the total calories, remaining calories to protein and carbohydrates. For the remaining calorie for carbohydrate, 908 calorie divided by 3.4 kilocalorie per kg will give me how much gram dextrose will be given to this patient. 267 gram dextrose divided by the remaining volume 1,509 multiplied by 100 will give me the percentage of dextrose solution which I have to order for this patient. And so I ordered 17% dextrose for this patient. Rate of amino acid dextrose infusion divided the total volume of this protein and carbohydrate by 24 hours will give me 63 cc per hour. Suppose I want to give the 3 macronutrients in one bag. It is very simple, like more simple than the previous one. Suppose I need 1,000 total calories, 1,800, protein 88 grams, and the fluid 2,000 cc. I have to calculate lipid or calculate lipid first. 30% lipid will equal 540. 540, if I give 10% solutions, will divided by 10 kilocalorie to gain how much gram of fats I will give, and then divided by the volume of solution and multiplied by 100, giving me the percentage of lipids which I have to order in my sheet, 2.7%. It is a mathematical method to calculate how much percentage for every macronutrient you have to give to the lab to prepare you in the nutritional. Protein 88 gram divided by the total solution or total fluid 2000 and multiplied by 100 will give you 4.4% of amino acid. Timing by 4 to get how much calorie of protein equals 352. After that, dextrose will be the remaining one will be 900. 900 divided by 3.4 kilocalorie per gram give you how much gram dextrose you will give. And the percentage will be 13.4% of dextrose solution. And so, as we see, there are many methods of ordering the calorie requirements for TPN to your patient. If you have standard solutions, as we said, you have to calculate the calorie and you change this calorie to gram and then change the gram requirement to volume in your standard solution. If you have lab in your hospital, you have to calculate the percentage for every macronutrient you are going to infuse your patient. And so, suppose I have 100 gram protein, how much it represents to the total volume, how much percentage, and I need percentage, 20% carbohydrates, 10%, and so on. Infusion rate, the rate of amino acid dextrose lipid infusion, total volume by 24 hours will be 83 cc per hour. Additional sterile water to standard total parenteral nutrition. We have, suppose your formula calculated in 1,800 and the fluid requirement for your patient is 2,400 or 2,500. You have to give the difference as water or fresh water or as IV normal saline. Fluid needs, suppose the fluid needs 2,450, exceeding the nutritional formula, you have to give the difference as sterile water or as needed. This is an example of nutritional standard sheet for nutrition support, which you order or which you sent to the pharmacy for preparing your solutions. You have to be sure from the name of the patient and administration and route of administration. In either enteral nutrition or TPN, you have to write this sheet. You have to write all the electrolytes which you need. Also dextrose, how much, amino acids, how much, lipid, how much. Even you write in grams or you write in percentage, as we explained now. Also, you have to add the vitamins and the trace element, and if you need insulin, if the patient is diabetic, trace element you have to write. Suppose you want to add some drugs as H2 antagonist or proton blockers, you can add here, and you have to write the rate, how much ml per hour, and the volume, total volume, how much, and which method you will give, continuous infusion or the cyclic infusion. You have to mention this in your sheet. Of course, when you write nutritional sheet, you have to monitor your patient as a feedback monitoring for any complications could be happened from TPN nutritional support. Initiation of TPN always start slowly and also stop slowly. This is a rule. To avoid, start slowly to avoid the refeeding syndrome, which will occur mostly in cachectic patients or malnourished patients, severely malnourished patients. If you push nutrition support, even with enteral nutrition, if you push the nutritional support very fast, you will get refeeding syndrome complications, which is manifested by hypokalemia, severe hypokalemia, and hypophosphatemia, which predisposes to severe arrhythmia up to arrest. If central access is not available, peripheral parenteral nutrition should be considered, as I said at the beginning. As protein associated with few metabolic side effects, maximum amount of protein can be given on the first day, up to 60, 70 grams of protein per liter. We can give them protein, no problem. You can give rapidly, or the maximum amount can be given in the first day. Maximum carbohydrate given the first day is 150, 200 grams per day, or 15 to 20% final dextrose concentration. Don't use high concentration in first, second day. Always we proceed over gradually up over 2, 3 days, 4 days to avoid refeeding syndrome and other complications. Dextrose content of parenteral nutrition can be increased if capillary blood glucose level are consistent with than 180 mg%. Intravenous fat emulsions in parenteral nutrition in general can be increased if triglycerides are less than 400 mg%. And we have to follow really the triglycerides in the first week, even daily or twice per week, to be sure the patient not suffering from hypertriglyceridemia. Fluid needs, sorry. Fluid need, as I told, if the patient need more fluid than the parenteral formula fluid content, you have to add the difference to compensate for this. Transition to enteral feeding in pediatric and in adult also in general. Try to taper more slowly. Don't stop the TPN suddenly. Otherwise, your patient will suffering from rebound hypoglycemia. And specifically in infants or pediatric, we have to avoid this complication. Generally, parenteral nutrition is continued till 70 to 80% of energy needs are met enterally. When you shift from total or enteral from TPN to enteral nutrition, you have to be gradual withdrawing the TPN solutions, not all of a sudden, and be sure your patient is taking adequate enteral nutrition, about 70 to 80%. Rebound hypoglycemia, if you stopped it, and sometimes we stop it and add 10% dextrose to be sure the patient will not suffering from rebound hypoglycemia. If adults receiving oral or enteral nutrition sufficient to maintain blood glucose, no need to taper TPN. Medications could be used with TPN. Yes, some medications could be added, like insulin, like selenium, zinc chloride, ranitidine, heparin, octreotide. Some drugs, metoclopramide, could be added to the TPN, but avoid injection only through the route of injection or through the route of supplementation of the drugs, not the line, not the pathway of the nutrition, because the infection rate is very high really. And so we always try to keep the IV infusion as a separate line for TPN solutions, not manipulated. Infusion schedules may be continuous parenteral nutrition. We give over 24 hours to avoid the nursing interruption and the patient will be tolerated more adequately and the nursing time will be spared. And even touch contamination is less if you give as a continuous parenteral nutrition. But sometimes, but of course, it has its disadvantages. It may lead to patient persistent anabolic state and increase the lipid storage by liver and reduce mobility in ambulatory patients, and it change or altered insulin glucagon ratio. And so mostly we prefer cyclic PN, usually over a period of 12 to 18 hours. Its advantages approximate normal physiology of intermittent feeding. The patient of us, there is intermittent feeding, ideal for ambulatory patients and allow normal activity and improve quality of life. Cyclic PN advantages maintain a nitrogen balance, more positive balance actually, and more visceral proteins, and more better than continuous. Disadvantages not tolerated by critically ill patients, require more nursing manipulation, increased potential for touch contamination, increased nursing time. Monitoring for every nutrition support, suppose even enteral nutrition or parental nutrition, you have to monitor your patients routinely. Wait at least 3 times per week and at the beginning of admission to ICU. Also signs and symptoms of edema daily, you have to estimate and write it in nutritional sheet. Signs and symptoms of dehydration through central lines, through IVC, through purge variability, many methods for estimation of the volume state. Also fluid intake, output daily, very important, and adequacy of intake at least 2 times per week. And the nitrogen balance, nitrogen intake, nitrogen output difference is very important for estimating your patient. And always suspect if your patient exhibiting positive nitrogen balance through these estimations, these are prognostically very important and give you good prognostic signs that patients will be more better and more survive. Protein markers, which we depend on at serum albumin, it is really mostly a prognostically marker because of long half time, maybe 21 days or more. In mild malnutrition, it will be from 3.5, dropped to 2.5 to 3 in moderate malnutrition. Severe malnutrition is less than 2.5, and actually it is a prognostic marker rather than for follow-up of nutritional support. Other protein markers which has a short half-life as pre-albumin, 2-3 days of life, preferred for monitoring. Transferrin also 8-9 days. Retinol binding protein and somatomidine about 12 hours, 8 hours, and so this is better for as protein markers for monitoring. Nitrogen balance is very simple, really. You can calculate the nitrogen intake minus the nitrogen output, and as you know, gram nitrogen equal 6.5 gram of protein. And so you calculate how much protein this patient take all over the 24 hours, and how much urine output is excreted, and calculate the nitrogen balance difference. Will give you if your patient is on nitrogen positive or negative nitrogen balance. Serum electrolyte, blood urea, nitrogen, creatinine, 2-3 times per week. Serum glucose, calcium, magnesium, phosphorus, weekly or as ordered. Phosphorus is really very important, especially at start or restart of feeding, to avoid refeeding syndrome, because it's very dangerous to drop. And even if you find your phosphorus level, serum phosphorus is low, you have to be gradual with initiating your feeding, and maybe waiting for feeding support till you correct phosphate level. Serum triglycerides, baseline serum triglycerides, and weekly after, and take care of other solutions which you infuse as sedative as propofol. You have to calculate its volume and add it to the TPM formula. You consider it in your caloric requirement for your patient. Also, the respiratory quotient, very important to follow it if you have indirect calorimetry in your patient. And our target, as I said before, the optimum range from 0.8 to 0.9. If it is more one, either you overfeed your patient and you have to decrease your total calorie, or you decrease the carbohydrate content. If your patient exhibiting a respiratory quotient 0.7 to 0.8, this meaning fat and protein oxidations depending more than carbohydrates. And I think, and of course, I have to say something about the complications of TPM. You can suspect many complications, from starting of inserting your central line, the mechanical problems, pneumothorax, bleeding, infection, and so on, hyperosmolarity and electrolyte disturbance, hypokalemia, hyperkalemia, all complications you can suspect and you have to avoid, and especially if carbohydrate excess and cholestasis, and these lead to problems in the liver. And so also we have to see and follow up the lipid profile. If you find your liver function test is increasing, this meaning you have to go down with carbohydrate, especially after the first week, second week, you may face a problem of cholestasis, and this is inside the liver, and so you have to go down with carbohydrate. Next week, inshallah, I will concentrate on trace elements. Thanks for you. Good luck.
Thank you, Prof. Ansari, for this very informative lecture. I think, as I said before, science everywhere in the books, but you will not find this experience except in our webinar in a mega online course, and from expert person like Professor Ansari. And I think this type of calculation of the nutrition, or the nutrition as an item as itself in the ICU, it needs to be considered as one of the subspecialty itself, because it needs a lot of experience. It needs patients from the doctors also who are monitoring. The patient should be monitored, and the patient is chronically present in the ICU. It needs a lot of investigations, and it is not like something simple. It is an art, and a big art in the ICU. So we appreciate the lecture from and this information from our legend, Professor Ansari. And now I think any questions will be at the end of the lectures. We have next two lectures. The next lectures for the Professor Hazim and Dr. Hazim Yassin, and will be presented by our friend Professor Adil Ibrahim. So Professor Adil Ibrahim, go ahead, and please don't leave the webinar, because we have another lecture at the end of the night. So please go ahead, Professor Adil Ibrahim.
Thank you, Dr. Azam, for this wonderful introduction. I'm very honored to be with you tonight with all the stars of anesthesia in this media online anesthesia. Our topic today is very important tonight. It should be it is on patient safety in healthcare facility. As all of us know, that patient is the center of anesthesia care, and that's why safety is very important. And we know the safety may be related to anesthesia factors, operation theater factors, surgical factors, drug factors. That's why there's a special day this year on World Patient Safety Day 2020, it's September 17th, and it will be virtual and free of everyone to attend. Our speaker today is eminent speaker is Dr. Hazim Yassin, is anesthesia consultant at Ain Shams University with huge experience, 30 years in Egypt and Saudi Arabia. I'm being honored to introduce Dr. Hazim. Please, can start your lecture.
Assalamu alaikum.
Yes, please, go ahead.
Grateful thanks for my professors, my mentors, and it is of great pleasure for me to be between all my professors and mentors today. I'm very honored to share with you some information about the patient safety in healthcare facility, which is a great issue, especially nowadays. Very simply, if you can imagine, you have a flight ticket and you hear that a Boeing 757 is falling every day in 1999. But now we are in 2015 and you have a flight ticket also and you're going to the airport and you hear that 4 Boeing 707 is falling down with all the crews and the passengers. This is the data statistics that hospital medical errors in 1999 in USA was 90,000 per year, which increased 4-fold.
Would you be kind just to make a share screen, please? Sorry, slideshow.
Yes, it's okay.
Slideshow. You know that the slideshow that your
slides is not working, sir. Now slides okay.
But is this one? Back.
Yes. Now share, Dr. Saad.
It is shared, but is not a slideshow. Mostly that's the mood, yeah. Okay, that's fine.
Okay, I will make a slideshow. Now it's okay?
Down, you can see.
You see the right corner?
Yes.
Yeah, that one. There's this one, please. Yeah.
Okay.
Yeah, that's perfect. Yeah, that's the same one. Yeah. Okay. Thank you.
Objectives are clear. It's okay. Our objectives tonight to get some for this presentation. At the end of this presentation, we would like to make some points clear: definitions and importance of patient safety, history of patient safety, medical errors, organizations of patient safety, international patient safety goals, future of patient safety. The introduction, I said a few minutes that sometimes you find a slogan that hospital is dangerous to your health. How it comes? Because they are catching the statistics of the medical errors in USA. It was 90,000 in the year of 1999, and it increased 4-fold to become 440,000 on 2015. Our goals here to scope on the patient safety and the healthcare facilities, challenges, and the future. What is the the main target of our patient safety to prevention of harm to patients. It is said that human is error. Human is error, it means once there is a human working in any facility, there will be error. Our aim to make this error free of injury to the patient. So health care discipline, it emphasizes reporting, analysis, and prevention of medical errors to reduce the events. What is the medical error? Medical error is the negative or unexpected result stemming from either commission or omission. Commission is the wrong action. Omission, that you fail to do the correct action, leading to either permanent injury, increased length of stay in hospital, or unfortunately can lead to death. What is adverse effects? Adverse effects is harmful and undesired effect resulting from medication or intervention rather than the underlying disease, which is complicating the professional patient condition, which result in unintended harm to the patient by the act of commission or omission. Why we are caring about the patient safety? We are caring because we have lost lives. It costs too much. There is also multiple legal issues. What it costs? It is said that the statistics bring us to that 85% only of the expenses to the healthcare is going to the right side. 15% is going to compensate the medical errors. What is a sentinel event? Sentinel event is unexpected occurrence involving death or serious physical or psychological injury, according to the definition of JCI. Special causes variation, we should monitor these sentinel events, and also the National Quality Forum, which you call it serious reportable events. What does mean? That this event should not happen. This event is called never event. Okay, for these serious effects, either commission or omissions or adverse effects or sentinel events, what is the procedures taken by the healthcare organization to prevent or eliminate this harmful to the patients? The National Quality Forum, which is non-profitable, non-governmental organization, and which is very respectable in the USA, is taking care of multi-tasks, which focusing on the patient safety. What is the phase 1 endorsed patient safety measures? It can process to catheter-associated urinary tract. Some events very frequent and very important in the hospital. National central line CLABSI, central line associated bloodstream infection, and INR control coagulopathies. Checking wrong patient, wrong site, wrong procedure, and process of faults in the hospital, drug overdose, fire, medication errors, maternal death, suicide, perinatal death. She is focusing on the most frequent sentinel events. Sentinel events, when it occurs, it needs root cause analysis to search. It is like the ice. It's like the iceberg. It's only few ice space, and then in the roots there is the biggest, like what happened to Titanic. And near miss. How can this happen? How can these two ships is very close to make an accident, and how can these two flights is going to just a few seconds between an accident? This is a near miss. What is a near miss? It is a potential medical error, which is caught prior to the administration to the patient. That you have wrong medication, and the nurse is going to give, and suddenly somebody catch it, or the one who is giving the medication itself, or the doctor who wrote the medication itself, or the pharmacist who is dispensing the medication, he catched it. And like surgical timeout, sometimes there is a wrong mark on the wrong site, or a wrong patient, or a wrong procedure. How can the healthcare organizations overcome these great events? The WHO make us a surgical safety checklist, which is very common for all surgeons and anesthetists, to sign in before, to be read out before anesthesia, and to time out after, and to sign out after the procedure. Sign in before the anesthesia, time out before the surgery, and sign out after the surgery. We will say it in details. And the most active organizations in the healthcare is Agency of Healthcare Research and Quality. The Agency of Healthcare Research and Quality in 2013 is reporting the patient safety practices. It reported two big items. The first item is 10 strongly encourages steps to prevent and to minimize any medical error, and 12 patient safety practices which should be encouraged. There is a 10 which is mandatory, and there is 12 which is preferable to be followed up. We will give a brief focus on it. The first one, the strongly encouraged implementation, is hand hygiene. Hand hygiene, I'm talking to my professors and my colleagues of all anesthetists and intensivists. Let us talk honestly, yani how frequently we wash our hands, and we make proper hand hygiene between each patient and another. How much frequently we are making high performance hand hygiene of 5 moments before catching the patient, before going to after catching the patient, before before holding any medication, after touching any, at the 5 moments, as all we know. And then the strongly encouraged implementation is barrier precaution. This was published in 2013, before the pandemic. Maybe a lot of healthcare workers did not pay any attention for this PPE before this pandemic. I know a lot of healthcare providers who wasn't caring about this PPE, and they were not oriented about what it can lead to hazards to the patient and to his colleague and to himself. The third one is intervention to reduce urinary catheter use. Catheter-associated urinary tract infection. What is the first step to do? There is a catheter reminder, which is indication. What is the indication? What is the expected duration? When to remove? Who can remove? And now with the great effort of the Agency of Healthcare Research and Quality, it is we can delegate the nurse to initiate removal protocols. Fourth one, reduce pressure ulcers, which really is great issue. Pressure ulcers and bed sores is a great issue in all chronic patients, especially if diabetic, if peripheral vascular disease, if they are long-standing, if they have stroke, if there is limited movement from bed. How to reduce pressure ulcers? There is multi-component interventions which can lead to, like there is schedule, and there is a stressing point, which include all the pressure area and the daily checklist, and turning the patient from side to side every 2 hours for the ICU, and for the regular patients every 6 hours. And then the most important, really encouraged implementation for the prophylaxis of venous thromboembolism, which is great issue in all the patient, all recumbent patient, all high-risk patient, all post-operative patients, because it is one of the 3 killers for the bedridden patient, the DVT and stroke, and the chest infection, and the bed sores and the pressure ulcers. How to improve our prophylaxis for venous thromboembolism? By calculating the risk factors. And there is a checklist, which is, can you calculate the risk factors according to this risk factors? Either if there is no contraindication, the patient go for low molecular weight heparin. If there is any contraindication, or there is low risk, we can go to mechanical pneumatic device for protection of DVT or venous thromboembolism. Coming to the most common ICU is the central line insertion, CLAPSI. Central line insertion is, as our professor, Dr. Samir, for TPN, of course, for all the indications, for TPN, for inotropes, for monitoring of cardiovascular monitoring, for the difficult peripheral lines, a lot of indications. There is a checklist for the central line maintenance bundle. This bundle is of great focus. Here in Saudi Arabia, they are making in our military hospitals and a committee for CLAPSI, only for CLAPSI, including all the head of ICUs all over the kingdom, and they are making a project which is followed up by the higher authorities of MOH and the military hospitals every month. Then the use of sonar guided central line replacement. Of course, we learned it from our professors long time ago by blind insertion of central lines and arterial lines. But recently, now with the advances of the sonar and the echo, it is vascular access is prohibited to be on blind basis, as long as there is a facility of central line with the sonar guided. And then the Agency of Healthcare Research is also focusing on pre-operative checklist and anesthesia checklist. It is parallel to the MOH checkout, which is patient identification, site verification, NPO preparation, escort verified, consent signed, history and physical, immediate note, site marked right and left, and armband, and supplies, special equipment, antibiotics orders, antibiotics given, and preoperative meds given. The 9 is the VAP bundle, which is very common in the ICU as ventilator-associated pneumonia, bundle is very common for the long-standing ventilated patients. And now it became ventilator-associated events, not only pneumonia. Procedures to eliminate VAP bundle is head of bed elevation and oral care with the chloroxidine and subglottic suctioning with tracheal tubes and sedation vacations, as all we know that the sedation should be interrupted in the ICU before the weaning as a preparation. The ninth one and the last of the strongly encouraged implementation, do not use. What is do not use? Do not use hazardous abbreviations. Why do not use hazardous abbreviations? Because there is a list of abbreviations which is completely prohibited now. And JCI and CBAHI, if they found these abbreviations in any files, they are making a great problem and making maybe stopping the they does not validate the CBAHI or the JCI accreditation. What are these abbreviations? U, simply U for unit. No, we should write unit. IU, international unit, it should be written international unit because it is maybe mistaken with the intravenous. OD, once daily. No, it should be written once daily. And zeroing, it should be 0.0. And letters like sodium, Na, no, it should be written sodium bicarb. Potassium should be written potassium, and so. What is the encouraged implementation? There is 12 encouraged implementation. We will run very fast on it. That first one is multi-component intervention to reduce the falls. Falls now is very important for old age and for multiple comorbidities, for stroke patients, for pediatric with unaccompanied by mothers. They are talking many procedures to reduce these falls. They are increasing the light. They are making notes. They are making arm marks. Clinical pharmacist should be added to the staff of the hospital to reduce adverse drug events. And what about doctors' writing? Doctors' writing really is very fantastic. Sometimes I may spend 2 days to read one line of one of my colleagues. So computerized provider order entry. And alhamdulillah, thanks God, our healthcare facility now is 100% computerized. Medication reconciliation. We should know the patient history, what kind of antihypertensive he's taking, what kind of oral hypoglycemic. So to be on the same run. Obtaining informed consent. Consent is mandatory for all invasive procedures. Only except if there is a great risk and there is severe emergency, we can use it. Without emergency. Use of surgical outcome measures and report cards, such as the American College of Surgeons National Surgical Quality Improvement Program. Practice to reduce radiation exposure. Of course, if there is no need for more exposure, no need to put the patient for these hazards. Documentation of patient preference of life-sustaining treatment. It should be, of course, it needs some places of high knowledge and high level of living. Rapid response system. Rapid response system, RRT, is really reducing the code blue too much. And we induced in our hospital here, since 2 years, it reduces the code blue outside the ICU by 50%. Utilization of complementary methods for detecting adverse event medical errors. We encourage the reporting. We give the safe culture. We give just culture to make all the staff comfort for reporting, and team training is a must. Use simulation exercise. Maybe this is not in every place, but we usually make major disaster drills, major rapid influx drills. What about the effort for the governmental and accreditation efforts? A great efforts done to reduce the risk for patient harm, and the federal government in USA. Of course, we have Dr. Barbara. We may help us in the updates if there is really many organizations sharing in the governmental and accreditation effort to reduce the patient harm. Patient Safety and Equality Improvement Act in 2005, it states that established confidentiality and privilege protective for the patient safety, which is organization must have a culture of safety. If the healthcare organization have this a culture of safety, then all the healthcare providers can report smoothly for the near miss, for the medical errors without fear. And the established patient safety organization, it is sub-organization from the patient safety and equality improvement organization. It's a standard event data collection and reporting. Patient safety organization also approved to the primary organization of ARHQ. The standard events data collection and the patient safety organization privacy protection center was created also by the main organization and was processing to do all new recommendations. In October 2008, the Centers for Medicare and Medicaid Services, which is the main two healthcare item facility categories in USA, it was withholding the Medicare reimbursement for 10 hospital-acquired conditions. It means it stopped the payment for the health insurance companies if any event of these 10 events happened in 2008. And they increased the items to 14 conditions, which we will mention now. These conditions were not present on admission. If the patient is admitted to the hospital without these problems and he developed any of these 14 problems, then the healthcare insurance will not pay to the hospital. What is these conditions? Foreign object retained after surgery, air embolism, which is very difficult to happen outside the hospital, blood incompatibility if the patient received the blood of not his same group, stage 3 and 4 pressure ulcers, and falls and trauma, which lead to fracture or intracranial injuries or burn, maintains of poor glycemic control, either diabetic ketoacidosis or hypoglycemic coma. It is one of the major incidents which can make a condition preventing the payment to the hospital. Catheter-associated urinary tract infection, UTI, vascular clepsy, vascular catheter-associated infection, surgical site infection, mediastinitis after CABG operation, and surgical site infection following bariatric surgery or laparoscopic gastric bypass, surgical site infection in spine, in neck surgeries, in shoulder and the elbow, surgical site infection following cardiac implantable electronic devices, and deep venous thrombosis, thromboembolic events following certain orthopedic operation or hip operation. For all these 14 conditions, they stop paying the hospital. So it is very stressful in hospital administration. So all the hospital administration will stress and focus on the patient safety, that these conditions not to happen to any of their patients. And so it is reflected on the staff attitude. What are the accreditation standards? There is many accreditation organizations, which of course the most popular is the JCI, Joint Commission of International, and NCQA, National Committee for Quality Assurance, and which is focusing on the patient safety. And the JCI separated the patient safety survey on 2014 to a separate chapter, and a separate surveyors is going to check all the files and to check all the policies and procedures for patient safety, and even they make a separate chapter and separate book for patient safety for guidance of the hospital, which is going to be accredited or to be re-accredited. For the patient safety goals and safe practices, JCI make national patient safety goals, which is 6 safety goals. All of us know it by heart, so I will not repeat it. But WHO is also sharing the JCI. It's very good vision since 2005 in collaborating the Center of Patient Safety Solutions. The WHO established in 2005 this collaborating Center for Patient Safety for evaluation, adaptation, coordination, dissemination, acceleration, improvement in patient safety worldwide. And it precises 10 events in these circumstances. What is the 10 events? It has 19 items surgical safety checklist first, and increase teamwork. We mentioned the surgical safety checklist in the previous one, and surgical timeout before induction of anesthesia, before skin incision, and before patient leaves after the OR, before the recovery. What are the 10 facts about patient safety from WHO? WHO make 10 facts. The first one, patient harm is the 14th leading cause of global disease burden. It is preceding and it is costing more than management of diabetes and management of hypertension, management of the ischemic heart disease, and management of coronary heart disease for the harm. Fact 2, while in hospital, 1 in each 10 patients is coming with a comorbidity, it will go out from the hospital with another comorbidity related to the medical error or to hospital-acquired infections. Fact 3, unsafe use of medications harms millions and cost billions of dollars. In USA, in 2002, about $26 billion was expenses. In 2005, it was about $38 billion. Fact 4, 15%, as we said before, only 85% of the expenses on healthcare goes to the right side. 15% goes to adverse events. Fact 5, investment in reducing patient safety incidents can lead to significant financial saving. So the patient needs these true investment to go to them by the right way, by reducing harm, by reducing the sentinel events. Fact 6, hospital infections affect 14 out of every 100 patients admitted, as every 1 of 10 will go with another comorbidity. Fact 7, more than 1 million patients die annually from surgical complications. And sorry, this number is limitedly reduced every year. We hope in the next eras that we can overcome these surgical complications, and we hope to reduce these numbers. Fact 8, inaccurate or delayed diagnosis affect all settings of care and harm an unacceptable number of patients, which is the future of patient safety, to reduce these delayed diagnosis and go to the proper interference at the right time. Fact 9, while the use of radiation has improved healthcare, but overall medical exposure should be reduced. Fact 10, administration of errors accounts for up to half of the medical errors. The medical errors, half of it due to administration, not due to system, not due to personal, not due to individual. The National Quality Forum also established in 1999, it has CMS never events identified for bloodstream infection, objects flaccid patient surgery, urinary tract infection, air embolism, and bloodstream infection, bed sores, falls. Identified measures for medication safety, healthcare associated infections, falls, pressure ulcers, and tried to reduce this with the cooperation of the National Quality Forum, with the Institute of Healthcare Improvement. Why? It makes work with the organization to move from separate silos to the system level of patient safety, to build measures for early warning signs. Early warning signs for RRT also can reduce morbidity and reduce mortality and death. To identify also the global trigger tool, it initiated, the Institute of Healthcare Improvement initiated global trigger tool. Why? To identify the adverse events through a retrospective review of patient medical files. It goes to the severity rating. It categorized to 9 categories, A, B, C, D, E, F, G, H, which is the harm to the patient classified to no harm, or first one category, circumstances of events that have the capacity to cause error, category A. B, an error that did not reach the patient. C, an error that reached the patient but didn't cause harm. D, an error that reached the patient and required monitoring or intervention to confirm it resulted in no harm. But from E until I, it's here is the harm. E, temporary harm happened to the patient, but required intervention to fix. F, temporary harm to the patient and required initial or prolonged hospitalization. G, permanent patient harm. H, intervention required to sustain life, like CPR, like mechanical ventilation, like PCI, and for category I, it is patient death. And the global trigger tool also reviewed the process where to look to reduce this harm which happened to the patient. We should look for care for healthcare providers, for the medication process, either dispensing or writing, or for the surgical procedures, the right process, the right policies, and for intensive care. Critical care areas are one of the areas it should be focused and improved. Perinatal care, so caring for the mother and for the baby, and at last, the emergency department. We hope in the future for all these healthcare organizations to collect together their efforts and to give us proper policies and procedures. And we hope all the healthcare facilities and individuals follow these policies and procedures to reduce the risk for the patients who is coming to the hospital to be treated, not to be harmed. And I hope I covered in flash way. And inshallah, in next sessions, we may expand in details. And thank you. Any questions?
Thank you very much, Dr. Hazem. The question I think I could to start with you later on. And again will be Dr. Assam Bana.
Thank you, Professor Yassin. I think this lecture is one of the most difficult items we face credential committee, I think, like this. And you give us a lot of expression, which is strange and very difficult to know away from one in the committee or in the members of the credential committees. And as you mentioned, I always say to my students, medical students and my residents, that our mission, the first mission of our specialty in the field is safety for the patient. Safety for the patients plus safety for the physician. So I'd like to appreciate your effort and making this very difficult issue very simple for us. And we hope to meet you again and again to clarify a lot of this specialty. And now, thank you so much. And if there are any questions be submitted for you at the end of this scientific party. And now we are going to the best of the best. We are shifting now from east to the west. Are you awake, Barbara?
I'm right here.
Okay. We are now going from east to the west, and we will provide the attendees with the experience from the west, from USA, as we said in the first of our introduction. And she will deliver, Barbara, a very interesting lecture about my favorite specialty, neurosurgery, neuroanesthesia. And Barbara is MD and Master of Business Operational Excellence and Fellow of American Society of Anesthesiologists, is an Associate Professor of Anesthesia in at the Ohio State Wexner Medical Center, Columbus, Ohio, USA. She specialized in the neuroanesthesia at the Tertiary Trauma Stroke Center, and she is a co-director of the Ohio State University Preoperative Assessment Center, where medically complex patients are optimized before surgery. She is actively involved in research, medical education, and serves on multiple local and national committees. She has a Master of Business Operational Excellence, as I mentioned, and is certified as a Six Sigma Black Belt. I think this belt is away from the karate belt.
Right.
Okay. Okay. And both from the Ohio University, Fisher College of Business. She is passionate about continuous process improvement, reducing waste, and improving flow in patient care activity. She will deliver a lecture for space occupying lesion, management of the brain tumor. So please, Barbara, floor is yours. Go ahead. Thank you.
Okay. Hello, everyone. Yeah, so my specialty is neuroanesthesia. So today I'm going to talk about just supratentorial brain tumors and anesthesia. I'm going to deliver a kind of a basic review lecture. So our objectives for this are going to be to state the most common type of supratentorial tumors, state the effects of PCO2 on cerebral brain perfusion, intracranial pressure, state the effects of the various anesthetic agents on cerebral perfusion, and rate the cerebral metabolic oxygen consumption, and list 3 ways to lower intracranial pressure during anesthesia. So what is supratentorial? Well, that is the area of the brain that is above the tentorium. So here's kind of a schematic picture. So most of the brain is actually above the tentorium. Below the tentorium is going to be your brain stem and your cerebellum. Things that may go wrong in the supratentorial area of the brain can be a primary brain cancer. You may have metastatic brain cancer, a hemorrhage, an infection, and these all may be intraaxial or extraaxial. Supratentorial brain tumors make up, the primary brain tumors in this area make up about 55 to 60% of the supratentorial tumors. Of these, gliomas make up 78% of adult malignant brain tumors. Gliomas rise from the glial cells of the brain. Glial cells can subdivide into different cells. They can divide into astrocytes, ependymal cells, oligodendroglial cells. There's also meningiomas that can occur in the supratentorial area. These are of the non-glial origin, and they make up about 15 to 18% of primary intracranial tumors. They're usually attached to the dura, and they're usually vascular tumors. There's also metastatic tumors that occur in the brain. Most commonly, these will be from melanoma, lung cancer, and breast cancer, although other types can occur also. So the World Health Organization, WHO, designation. So in 2016, WHO updated their classification of central nervous system tumors, and they added phenotype and genetic parameters to their definition. Previously, they had only used histologic data to classify these tumors. But still, if someone has a grade 1 WHO designated tumor, it's still the least malignant. And if you have a grade 4, it's still the most malignant. So this is a little bit more about the WHO grading system. So again, grade 1 tumors basically don't have any criteria. They're slow growing, they're non-malignant. Patients with these type of tumors usually have a positive long-term survival. Grade 2 tumors, they'll have one of the WHO criteria. They're still slow growing, but they may reoccur as a higher grade tumor. They can be malignant or non-malignant. Grade 3 type WHO tumors meet 2 criteria, such as they're anaplastic and or increased mitotic activity. They are usually malignant, and they often recur as higher grade tumors also. And the worst grade is grade 4. These tumors meet 3 to 4 of the criteria, and they are aggressive bad tumors. They're fast growing, they're malignant. So that's the worst type. Now we're going to talk about basic principles of neuroanesthesia. The most important thing, I think, when we talk about neuroanesthesia is the Monroe-Kelly doctrine. This is pretty much makes up all of how we do neuroanesthesia. So it's really important to review it and really understand it. So what this says is that the skull is a rigid container. And in this rigid container, you're going to have 3 components. You're going to have the tissue component, which makes up roughly 80% of the space. You're going to have the blood component that makes up about 12% of your space, and the cerebral spinal fluid component, which makes up about 8% of the space. Now, when you have a mass that starts growing in one of these components, because the skull is rigid and because all the parts have to equal 100%, if one part increases, obviously the other two parts have to decrease. And the brain has a capability of tolerating this and compensating to a point. So, but unfortunately, at some point, the brain will not tolerate it anymore. And all these compensatory mechanisms fail. And when this happens, the intracranial pressure arises abruptly. And the brain may herniate through different areas of the brain, and if the ICP is too high, and this is a medical emergency. This is a picture of the intracranial pressure volume curve. This is also a real important curve to remember when you're talking about anesthesia for patients with brain tumors. So what this shows on the bottom is that as the intracranial volume goes up, the pressure goes up. On the left-hand side, the pressure goes up. So as you can see, it kind of moves along with not much of a change, but at some point, and you don't actually know for each patient where this point is, the pressure will abruptly increase. Now I'm going to talk a little bit about the cerebral blood flow to the brain. The brain gets 15% of the cardiac output, but it is only 2% of the total body weight. The brain has a high metabolic rate of oxygen consumption, needs a lot of oxygen. The blood is supplied to the brain by the internal carotid arteries, which come off the common carotid arteries, and the vertebral arteries, which come off the subclavian arteries. So these go into the brain, and then they make something called the circle of Willis, which is an anastomosis of the terminal arterial branches. So this is kind of a picture of the circle of Willis. You can see there's anterior cerebral arteries, internal carotid arteries, posterior carotid arteries, and they're connecting vessels to connect them all. There's the anterior communicating artery and the posterior communicating artery. Now we have to talk about, as you get blood to the brain, there's something that you also have to remember, which is your cerebral perfusion pressure. So we have to keep a certain pressure in the brain so the brain tissue gets oxygen. So how you can calculate this is the mean arterial pressure minus the intracranial pressure, and or you can also use a CVP pressure. This can also be calculated if you don't have a MAP pressure, if you don't know what your mean arterial pressure is. This can be calculated by hand by taking your systolic pressure, subtracting off your diastolic pressure, dividing that number by 3, and adding on your diastolic pressure. That would give you a mean pressure. So this is an important concept to know what your cerebral perfusion pressure is. So the brain has cerebral autoregulation. So normal autoregulation will occur when your cerebral perfusion pressure is maintained between 50 to 180 millimeters of mercury. There's going to be some chemoregulation changes when your plasma CO2 kind of affects your cerebral vascular resistance. So hypercapnia, when you have high PCO2, this will dilate your cerebral arterioles and will increase your blood flow, which will increase your ICP. And the reverse is also true. If you have hypocapnia and you lower your PCO2, you'll cause vasoconstriction. This will decrease your cerebral blood flow and decrease your ICP. Now, if you have hypoxia, less than 50 millimeters of mercury, this will also increase your cerebral blood flow and your ICP. So if you have a patient, so that's a normal patient. If you have a patient with uncontrolled hypertension, their cerebral autoregulation, their curve is shifted to the right. So these people may have cerebral ischemia at pressures we normally would consider normal because they're used to such high pressure. So that's always something to remember if you have a patient with chronic hypertension that's really not treated, that they're going to need higher pressures than the normal patient. So their curve is going to shift to the right. What that means is that when a normal patient may not have cerebral ischemia till their MAP or their cerebral automatic pressure is less than 50, these people might have it at 50 or 60 or 70. They need more pressure because they're used to higher blood pressure. This is kind of a schematic of all those things we just talked about: cerebral blood flow, percentage versus your perfusion pressure versus your PCO2 and your O2. So cerebral blood flow is on the left side. I wrote that in blue. And then all the pressures are along the bottom. I highlighted 50 to 150 because that's the perfusion pressure that will be a normal cerebral blood flow. And this is another graph that pops up in tests and things. And it's just a nice schematic to kind of remember how these all work together. Next, I'm just going to touch on cerebral spinal fluid. The normal volume of cerebral spinal fluid is about 100 to 150 milliliters. It's made in the choroid plexus and the cerebral ventricles. It's made at a rate of about 0.3 to 0.4 milliliters a minute. And then it's reabsorbed into the arachnoid villi, and then it goes back into the venous system. What is the role of cerebral spinal fluid? It's kind of the cushion for the brain. It surrounds the brain, the spinal cord cushions it. You will go through in 24 hours it will be renewed 4 to 5 times in a normal person. Normal cerebral spinal fluid has these components that I listed. Really, it's not important to memorize them all, but to know that you should not have bacteria, viruses, fungi, cancer, blood cells, and even white blood cells should be extremely rare in your cerebral spinal fluid, maybe less than 5. Now I'm going to talk about the angry brain. So when all these compensating mechanisms I discussed earlier, when they kind of have reached their limit and you're not compensating anymore, your increased intracranial pressure is not being mitigated by any reason, you may have these herniation syndromes. And these are the ones that are in the supratentorial type herniation syndromes. So the most common, or the one I always think of, is the uncle herniation, when the medial temporal lobe is squeezed by a unilateral mass across and under the tent-like tentorium that supports the temporal lobe. The subfalcine herniation, the cingulate gyrus is pushed under the falx cerebri by an expanding mass that's high in the cerebral hemisphere. And then you can also have central herniation. Both temporal lobes herniate through the tentorial notch because of the bilateral mass effect or some sort of diffuse edema of the brain. These are all bad. These are all emergencies. So what would you see? Well, for the uncle transtentorial herniation, the sign that's the most common, or probably the first sign, is you have unilateral pupil dilation, which we call a blown pupil. That's because there's pressure on the parasympathetic nerve fibers of the third cranial nerve. Then you might start getting extraocular muscle paralysis and contralateral hemiplegia. Subfalcine herniation, you're gonna get small reactive pupils. It kind of traps, this herniation is going to trap the anterior cerebral artery, causing some contralateral leg paralysis. Of course, headache with all these, they're going to get headaches. In central, you're going to fixed midline pupils, and you may have some decerebrate posturing. So now I'm going to talk a little bit about the anesthesia for these procedures. So the biggest goal of anesthesia basically is to save the brain from any secondary insult. It's already being insulted because you're doing surgery, and we want to keep it from having some sort of other insult during our anesthesia. So we want to reduce our ICP, or intracranial pressure. We want to optimize our perfusion pressure and decrease our metabolic rate of oxygen consumption, or the oxygen demand. So how can we do this? How can we lower our ICP? Well, the easiest way is to hyperventilate. So it's very easy if the patient's already intubated. If the patient is not intubated, you can make them hyperventilate before surgery if you felt that you needed to. But usually this is something we would do after they've been intubated. You would intubate them and hyperventilate them. And usually you get your PCO2s less than 30 is what we shoot for. This is a temporary measure. After 6 to 8 hours, our acid buffer system will revert and change the CO2 back to a normal level. So you can't do this like forever. It's very temporary. The next thing is positioning. So you're gonna wanna elevate the head of the bed. That maximizes venous drainage. You're also gonna wanna keep their head and neck in alignment, so you're not kinking off any of the veins in the neck. that lets the venous drainage occur. And medications, you can use furosemide, mannitol, 3% sodium, Decadron. Also, if it's really kind of a bad situation, the surgeon may also put in a CSF ventricular drain. That's actually, they put a burr hole through the skull and insert a little device that actually lets the CSF drain out, and that will lower the pressure in the brain. It's kind of temporary also. It won't last forever, but that's another thing they can do. So hyperventilation, we can have people, like I said, hyperventilate before induction. Once intubated, increase the respiratory rate to achieve PCO2 25 to 30 millimeters of mercury. Again, keep the head elevated, keep the neck and head straight. It's important to note, if you change the position of the patient from sitting to flat and they automatically start vomiting, this is a really bad sign of increased intracranial pressure. You may see that. And our medications, I'm going to go over these again. So medications, furosemide. Furosemide is a loop diuretic. It acts in the ascending loop of Henle in the kidney, inhibits sodium potassium chloride co-transporter. It increases the loss of sodium and water will follow. Mannitol is an osmotic diuretic. It will pull fluid into the vascular system by raising the plasma osmolality. This can also acutely alter your electrolytes if you give it too rapidly. You also want to use some caution with mannitol in patients with low ejection fractions, because as it pulls the fluid into the vascular system abruptly, this may lead to acute heart failure because these patients already have a low ejection fraction, and now it's almost like you just give them a big bolus of fluid. Same with 3% sodium infusion, this hypertonic solution. It pulls fluid into the vascular space to be excreted by the kidneys. It will raise your blood sodium level, and also you have to kind of be cautious with patients with cardiac patients, basically. And Decadron is a steroid. It reduces inflammation, and it's believed to decrease the swelling around brain tumors. Okay, so once you get our patient to sleep, we've done all what we just talked about. Now we're giving them volatile anesthetics. What's important to realize about these volatile anesthetics is that they will all increase your cerebral blood flow by vasodilation. They all do. This and secondarily will increase your intracranial pressure. They all decrease the cerebral metabolic rate of oxygen consumption, which is good. So typically what we do is we'll use less than 1 minimum MAC and hyperventilate to control vasodilation. It's hyper, not hypo. I put the wrong thing there. So that's kind of how you mitigate the fact that it increases vasodilation, but at the same time lowers metabolic oxygen consumption. The worst of these is halothane. I actually haven't seen halothane, but I don't know if it's used in other parts of the world. Halothane is the worst as far as increasing cerebral blood flow and vasodilation. Enflurane's in the middle. Isoflurane is the best of all three of those. And then sevoflurane and desflurane fit in around about the same as isoflurane as far as increasing cerebral blood flow. Nitric oxide is, the biggest problem with it is that it has a potential for pneumocephalus. You decide to use it, or if you decide not to use it, it does have that potential. IV agents that you can use, barbiturates such as pentothal, lowers the metabolic rate of oxygen consumption of the brain. It suppresses neurotransmission. It's titratable for burst suppression on the EEG. The hypnotic propofol is very similar to pentothal. Others, such as etomidate, you can use this also, but it can cause adrenal suppression if you give multiple doses of it. IV narcotics. We commonly use IV narcotics during brain surgery to attenuate the sympathetic response to surgery. You're going to select what you want desired on the desired length of the action of the drug plus its half-life. Just remember that if you use something that has a long-acting narcotic, this may cause problems when you're trying to wake your patient up. They may have excessive sleepiness and you don't know if it's from what you gave or if there's a problem with their brain. So it's always something kind of to remember when you decide on what narcotics you're going to use during surgery and or after surgery. Remifentanil is kind of a newer drug. It's an ultra short-acting opioid. You give it as an IV infusion. It can cause bradycardia and hypotension. Also, there's fentanyl, sufentanil, and alfentanil. Sufentanil compared to fentanyl, it's rapidly eliminated from the tissue when you compare it to fentanyl, but it's more potent than fentanyl. Alfentanil is the less potent of the, it's least potent compared to fentanyl or sufentanil. You may have to give some seizure prophylactic medications. A lot of times these patients will have seizures before surgery. They possibly could have them after surgery. So you may be giving them at any time during the perioperative period. The thing to remember about seizures during surgery is that under general anesthesia, if you have a muscle paralytic on board, you're not going to see that the patient had a seizure. You're not going to know unless you have EEG monitoring at the time. So you may not know they had a seizure, and then at the end of surgery, we try to wake them up. They're post-ictal, they may not wake up very well. So that's kind of just something to keep in mind. There's different kinds of IV anti-seizure medicines you may be asked to give during surgery. I've listed those. I'm not going to really describe them all, but you may be asked to give these. So review. Our objectives today were as follows. State the most common type of supratentorial tumors. State the effects of PCO2 on cerebral brain perfusion and intracranial pressure. State the definition of the Monro-Kelly hypothesis. State the effects of various anesthetic agents on cerebral perfusion and the rate of cerebral metabolic oxygen consumption. And list 3 ways to lower intracranial pressure during anesthesia. So here we go. So number 1, what is the most common type of supratentorial tumor? We discussed earlier, glioma is the most common type. Number 2, what's the effect of PCO2 on cerebral perfusion and the intracranial pressure? There's a linear relationship. Increase there as the PCO2 goes up, your cerebral perfusion also goes up. State the importance of the Monro-Kelly hypothesis. So that again is because the skull is rigid. There are 3 components. When one component goes up, the other 2 components have to go down to keep the pressure constant. Number 4, state the effects of various anesthetic agents on cerebral perfusion and the rate of cerebral metabolic oxygen consumption. The important thing here is that all volatiles will increase your cerebral blood flow and ICP, but decrease your metabolic rate of oxygen consumption. Cerebral blood flow effects can be attenuated with hyperventilation. IV induction agents will decrease cerebral blood flow and decrease your metabolic rate of oxygen consumption. List 3 ways to lower intracranial pressure during anesthesia. You can increase the head of the bed to facilitate venous drainage. You can hyperventilate the patient to lower your CO2, which will lower your ICP, and you can use different diuretics. Thank you. That's all.
Thank you. Thank you so much, Professor Barbara. Very informative lectures and for the basics of the neuroanesthesia. And I think there is no great difference between our techniques in the East and as well as the West. I like neuroanesthesia, and I hope to meet physically together very soon after Corona. And I think we enjoyed in this scientific party this night because we had an experience of intensive care from Professor Ansari, and I think I can say the next lecture of Professor Hazem Yassin about the ethics and safety in the OR or administration. And lastly, we finished by Professor Barbara in the favorite for me, neuroanesthesia. So I'd like at the end to thank all the attendees and the panelists. And it was a very good and big dose of scientific meeting today. So thank you for everybody who shared, and thank you for the panelists. And now the floor for our leader, Professor Saad Mahdi. Thank you, sir.
Thank you very much, Professor Assam. I don't believe there is too many question here tonight. Bro Adil.
I think you have question for Dr. Hazem about reporting the self-reporting. It is double sword, H as you said in the here, and what's your comment about that?
If I hear the question well, the question about self-reporting.
Medical errors and patient safety is an important topic,
Yes.
but if
Yes.
you report according to the quality, if any
Yes.
problem or mishaps or anything, you should report self-reporting or no.
Yes.
And because the comment here is, as you said, it is double-edged sword. So what's your comment about this one?
Yes, for the Joint Commission International last 2020, it encourages too much self-reporting, and it encourages the administration of the healthcare organization to make safety culture and to get a just culture, to give all the healthcare providers the courage to self-report any adverse event or near miss, because by the analysis of this adverse effects and adverse events and the near miss, we can improve our organization, and we can prevent these next events and the near miss from happening again, and it will lead to more self-confidence for all the healthcare providers, and encourage others to share in this self-reporting. The culture of no harm. The new culture is no harm. So no punishment. Punishment is prohibited for any administration because it prevents all the providers to any report or about any event happen. I hope the question is clear.
Dr. Hazem, please. I have a question for you.
Yes, sir.
For the OVR, do you encourage the anesthesiologist to report for the OVR or incident reports for giving good chance for teaching, for learning, and for education, and to encourage them not to be afraid from the administration for speaking about any incidents happened, even if it is small. I think this is a good way for teaching and for learning. Do you agree with me of this?
Of course, Professor Manna, self-reporting for anesthesiologists is very important, and really it is a challenge because of maybe of our Middle East and Arab culture. The punishment and the legal aspects is preceding the educational aspects. Really, the main view is how to protect yourself. Maybe also our health organization is not giving us the comfort feeling of, if you reported about any problem, we will cover you, we will help you, our legal assistance will be on your back. So the juniors can report to the seniors, and the seniors will discuss with them about how this event happened, how we can prevent, how we can improve our performance. And really, during maybe 30 years ago, during my residency, I was afraid to report about wrong medication given. And then one of really my mentors and my great professors from Cairo University, he told me, if you afraid, how can you meet your gut? If you afraid from me, what about our gut? Very simply. So never afraid from me and not afraid from your gut. Please, If you have any problem, report and ask the seniors and ask the more experts and get assistance. Never shy to get assistance. And so by this policy and by this protocol, please, we encourage quality-wise, Muslim-wise, doctors-wise, human-wise, to report about any medication error, any sentinel event, any near miss, so we can improve our performance.
Yes, we have a couple of questions for Professor Barbara, if you please. One of the questions, does furosemide have a superiority over other diuretics, Prof?
No, basically with neuroanesthesia, you're going to pick your drugs based on what your goal is and what drugs are available. Unfortunately, in the world, there's lots of drug shortages every time you turn around. So I can't say that furosemide is better than some other diuretic that maybe somebody might have access to if they didn't have access to furosemide. So the basic concept is diuresis. So using a diuretic that you have that will get the fluid out of the patient is really the most important, not as much what the drug is.
Continuing with this question, are you using mannitol and be followed by diuretics or only mannitol?
So usually, honestly, what we do is we use Lasix, furosemide, tenoffurosemide, and we use mannitol at the same time. Basically, we push our furosemide 10, and then we give mannitol, usually half the weight of the, whatever your person's weight is in kilograms, we give half that. So if they're 70 kilograms, we give 35 grams of mannitol, and we infuse that afterwards. And this is really right after induction. So we put the patient to sleep. We have 2 IVs and an A line, and we immediately, once a person's asleep, start the mannitol. So I give the furosemide with all my induction drugs, and then the mannitol starts right away. So that the goal is, so when the surgeon opens the dura, the brain is sunken in. It doesn't puff out. You want the brain to be what they call relaxed, but it's kind of like a dehydrated brain. So when they're cutting open the dura, the brain is sunk in. So that's why we do it. So, and that's how I do it.
Okay, one more question about the timing of giving Decadron or corticosteroids in the beginning or pre-operatively or intraoperative.
So
what is
your
the
patient.
advantage?
So your patient is going to have already seen the surgeon, obviously, and if they have a brain tumor, they're going to already be started on Decadron. That's like one of the first treatments the patient's going to have. So they're already on Decadron. So again, with induction, I usually give the 10 of Decadron, the 10 of Lasix with induction, with all my induction drugs, and then that will be continued by your surgeon post-op. But the patient's going to come in with that already, unless it's an emergency and they hadn't seen anybody and they just showed up in the ER with this horrible brain tumor.
Is there any room for making rapid sequence intubation, especially in the COVID era now with succinylcholine?
With brain tumor patients, is that the question?
Yes, this is a question,
So that's a really good question. I think if a person is worried about their patient having COVID, then I think that's totally reasonable to do a rapid sequence. I mean, I guess we don't, right now there's opportunities to have rapid testing done before they come to surgery, which wasn't present back in April. And we were doing everybody rapid sequence unless we felt that we couldn't intubate them. We were really worried about it. There's, you know, like a morbidly obese patient. So I think you have to take into consideration your patient population and how likely it is that you think this person might have the COVID. Now, that being said, since we're a stroke center, now all our strokes are being intubated in the emergency room before they come up for thrombectomies. And that may be done everywhere, I don't know, but we are doing that. They're intubated before you can come in the room.
Can I comment, Professor Barbara? I think there is we are afraid from succinyl for the increased intracranial tension, especially in brain tumor patient. So we have also alternative to make rapid sequence intubation with the presence of Rocronium. If we give a big dose of rocronium, and we have also standby and the reversal with sugammadex, so it is one of the alternatives to give rocronium in case of presence of rocronium and sugammadex in the institute. If we are afraid of increased intracranial tension by using succinylcholine.
Yes, that is true. I feel that the increased intracranial pressure with succinylcholine is theoretical. I've yet to see anyone herniate when I gave succinylcholine. So I kind of feel like that's a theoretical worry. That's my personal preference. So I would use Sux if I'm really worried about their airway because it's so much quicker. If they just ate and I don't know, and if I really am worried about it, I use succinylcholine. The only reason I wouldn't use it on that patient would be if they had I don't know what their potassium is, they have a giant burn injury, or they came in and they're already paralyzed and don't move anything, and I'm worried about their potassium going up. But your point is well taken. Rocuronium you can reverse if you have sugammadex. So.
What do you think about the moderate hypothermia, 32 to 33? Is it applicable intraoperative or is more in the intensive care?
I think that's more of intensive care, or if you have like an actually devastating cerebral injury with the vessels. We actually don't do that at OSU for normal craniotomies. We don't make them very cold. But if you had like a patient that had a cardiac arrest and had a brain injury, yes, they do that in the ICU.
The last question I saw here about the allowed hypotension, and for how long do you allow for the hypotension during induction of anesthesia or maintenance as a compensation to increase intracranial tension?
I'm sorry, I misunderstood. The hypotension?
The hypotension. What is the allowed figure for the hypotension during anesthesia for patient with high blood pressure as a compensation for increased intracranial tension?
So you're always going to want so generally speaking, you're going to want your MAP, the mean arterial pressure, and all these people to be about 80, right? I mean, that's, so if you keep it at 80, probably your hypertensive patients will not have a problem. It's when you let the mean arterial pressure go down to 50, which in a normal patient, that shouldn't be a problem. In a hypertensive patient, it will be a problem. So for induction and throughout all our brain surgeries and actually our back surgeries too, we keep our mean arterial pressures 80 and above. If we're really, really worried about perfusion in like a spine case, it may be even higher than that, maybe 90. So if you keep it at 80, everybody should be covered. And that's mean arterial pressure. Yeah.
Perfect. That's all I have. If anybody has any questions, he can go ahead. Thank you.
Roger, may I ask if you use hypertonic saline to reduce the intracranial pressure?
Do we use hypertonic saline to do what now?
To decrease the intracranial pressure?
We do that, honestly, we only do that in cases where it's such a bad situation. Our first choice is always mannitol. If we've used mannitol and let's say they did a craniotomy, they went to the ICU and they're still having problems. Let's say they already put a burr hole in, they're draining CSF and it's still a problem. That's when they'll start the 3%. And usually they come in and get a craniectomy. They just take part of the skull off. So not normally, but under extreme circumstances, we do.
Thank you very much.
Dr. Hazem, please, I have one ethical questions.
Yes.
We have a accreditation committee coming to evaluate our hospital and our university. And as you know, we are preparing everything at the moment. And yes, all of the staffs and the OR, they are ready. And we are really continuing the same standard after they are leaving, but not like the moment they are coming to check for the evaluation. Yes. What do you think for how long or every when the committee should come to evaluate for the safety of the patient and for safety of the staffs?
Okay. Which committee?
Committee of credential committee, the evaluation for the hospital, evaluation for the process of the anesthesia OR.
Yes.
Like Sibari. I mean, like Sibari.
Yes, I understood from the question. It is an external surveillance.
Yes.
Okay, the main issue in the success in accreditations depends on the proper preparedness. And proper preparedness needs simulation and needs a lot of drills and needs a lot of internal surveyor stress and needs checklists. First of all, delegate the continuous quality improvement and patient safety department should assign a competent, highly committed internal surveyors and giving them the checklist with policies and procedures. And these candidate surveyors go smoothly to the staff, friendly, and try to make them share their experience and try to delegate some of a selected, highly committed staff to help them in the survey. So the experience of the surveyors will be transferred spontaneously to the internal staff of anesthesia department, either consultants, registrars, residents, or even OR nurses and anesthesia technicians.
So it is a continuous process.
Yes, so it will speed the process. And repeating the survey and repeating the drill and simulations, it will help too much for everyone to get his rule and to rehearse his rule and to report what he did and to finish his documents needed.
Thank you, sir.
Thank you, sir. Thank you.
I'd like to thank Professor Samir Al-Ansari specifically, and I appreciate his presence with us, and all thanks for the speakers, and thank you so much, Professor Saad.
Thank you very much for all speakers tonight. Prof. Ansari, unlimited giving to us for his time and his for knowledge, and the library, Ansari Library, is fantastic resource for us. And Dr. Hazim Yassin, Prof. Barbara Roger, and Prof. Hassan Manna, Prof. Adil. And thank you very much, Anna. And thank you very much, Mr. Darawalsh, and for his excellent work with us tonight. And thank you very much as this distinguished webinar tonight. And really, I enjoyed listening and working with you. Thank you very much, everybody. Thank you.